Okay, today we're going to be talking about weaning for mechanical ventilation. And I think it's important to understand that not everyone needs to be weaned. Okay, weaning is really implies a process that leads to extubation or liberation from mechanical ventilation. But a lot of patients don't really need a process of weaning. You know, patients that go to the operating room, have surgery, they go to the PACU, those people aren't weaned. When they wake up, they can lift their head off the pillow, they're awake, they're breathing okay, they just pull the tube. There's no process really beyond that. What we're going to be talking about mostly applies to patients that have been on the ventilator for a longer period of time, usually days to weeks, and how to go about getting those people off the ventilator. So remember, there's a difference. We often use the terms weaning and extubation interchangeably. They're not really interchangeable, although we use them that way, and I will even use them. Everybody tends to use them that way. But oftentimes when we talk about weaning, we're talking about just extubation. Other times we're talking about this process that leads to extubation, a process which can take days to weeks, okay, or longer. Okay, so that said, when we're thinking about weaning or extubating a patient, what's the first most important process or most important factor that has to be met, or condition, I should say, that has to be met before we even think about going through a weaning process?
Consciousness.
Even before that.
Has to be getting better. The underlying process has to improve.
Okay, good. So the underlying process or cause for why the patient was intubated in the first place has to be improving or substantially better. Okay? Regardless of what the cause of the process was that got the patient intubated, obviously there are hundreds or different things that can lead to respiratory failure and intubation, but that primary process has to be improving or substantially better before you even think about weaning or extubating a patient. And although that sounds intuitively obvious, it's not always that obvious. And so one example is that oftentimes we'll get patients that come in during the night, usually during the night, late afternoon. They come in with bad pneumonia to the emergency room. They're in respiratory failure, they're very tachypnic, they're hypoxemic, they're on a non-rebreather mask, their PO2s are in the 50s, and they get intubated. They get intubated, they put it on a mechanical ventilator, they get put into the ICU where the night float intern, whoever, resident intern, take care of the patient overnight. And gradually overnight, and the patient, say, has pneumonia, gradually overnight, the patient improves, they sort of wean the FiO2 down. So now you come in the morning, and the FiO2 is, say 45%, or 50 to 50%, and you get a blood gas, and the pH is 7.4, and the PCO2 is 40, and the PO2 is 80, and the intern says, well, can we extubate this patient? So what do you think? Do you think that underlying pneumonia has likely improved that much? You get the chest x-ray, maybe it looks the same, maybe a little worse, but the gases are clearly much better than they were when the patient came into the emergency room. So has this process really substantially improved? Why is the blood gas so much better?
Because you're doing the work of breathing for them.
Well, the patient's on a mechanical ventilator. That's why you put them on the ventilator, right? So the ventilator's doing all the work. This person's on assist control with a rate of 12 or 14 or 16, and they're on positive pressure. Maybe you have some PEEP, so you've improved their oxygenation. So yeah, the patient's better, but that process has really not had long enough time to really improve significantly. Patient's blood gas is better, you're doing better in terms of keeping them alive, but you haven't really had enough time to reverse that process. So to think about extubating that particular patient is not really reasonable. Okay? On the other hand, if you have somebody that came in congestive heart failure with pulmonary edema, and during the night you had, vigorously diuresed that patient and aggressively treated their heart failure, and their chest X-ray is now clear, and that process has improved, that would be a patient that might be extubatable. Okay, so just keep that in mind because it's a common theme on morning rounds where people don't realize that they're better. The reason why they're better is because you're treating them with the ventilator. You take that ventilator away, what's going to happen to this patient with the pneumonia? They're going to go right back to where they were the night before, or very close, over a period of usually hours. Okay? So once you satisfy this condition, then there's at least, depending on how we do this talk and whether we combine things, another 12 to 14 different things that you need to think about and look at, before you really make a decision whether to start weaning or extubate a patient. So that's a lot of things to think about. We don't often talk about all these things on rounds, but I'm thinking about them, and I know the other intensivists are thinking about them, but a lot of times we don't ever address them unless they're a problem, and we don't talk about them. So that's what this talk is for, so that you guys can start thinking about those things. Okay? So I'm going to ask you, what other things would you be interested in looking at? What other things are important in terms of making a decision to decide whether somebody is ready to either start the weaning process or to be extubated?
So they need to be hemodynamically stable.
Okay, so hemodynamics. So hemodynamics are important. So you want them to be hemodynamically stable. What does that mean? What does hemodynamically stable mean?
So not on pressors, for one.
Okay, so ideally they shouldn't be on pressors. If they're on vasopressors, it should be minimal pressors. If they're on a significant amount of vasopressors, that person really shouldn't be weaned. Okay, because that implies that they're not adequately perfusing their tissues, which includes their respiratory muscles, and you're going to put a great strain and stress on that patient if you try and extubate them. Okay, what else besides pressure? So blood pressure. Anything else?
The respiratory rate is obviously important, but that goes with sort of lots of other things.
Okay. Well, when you're talking about hemodynamics, you're mainly talking about blood pressure
heart rate,
and cardiac function.
Yeah.
Okay. So let's talk about cardiac function. I know we've talked about this on rounds, I think this week, but maybe not, because I can't remember every week. Runs into the next week. So what are the hemodynamic consequences of positive pressure ventilation, mechanical ventilation? What are the effects on the heart function?
Decreased preload.
Okay, so one thing is decreased preload. What else?
Decreased afterload.
Okay, it also decreases afterload. Anything else?
Increased pulmonary pressures.
Increase or
Increase in pulmonary artery.
Okay, so it can increase the increased pulmonary artery pressures. Okay. One other thing, probably. The other one is it can shift the intraventricular septum from right to left. So it actually compromises the left ventricular cavity. Okay? Right to left. Okay, of these, what's the most important? Preload, far and away. Much more important than any of these other factors. Okay? So what's probably the second most important?
The shift.
Afterload. Okay, so if you have somebody who has heart failure or marginal cardiac function, and you have them on a mechanical ventilator for whatever reason, whether they were intubated because of the heart failure or that's just a coincidental problem, a comorbidity that's maybe contributing to their heart, to their overall respiratory failure, like some of the patients we had this morning, septic, pneumonia, maybe they have some heart failure thrown in. So what's the effect of putting that person on mechanical ventilation, that person with marginal or decreased cardiac function, decreasing preload and decreasing afterload? What's the main strategies for treating heart failure? Decrease preload, decrease afterload, increase contractility, which is up here, okay? So those are the three things that you try and do, right? So you're doing 2 out of the 3 of them with the ventilator. If you have somebody with marginal cardiac function, and now you are going to extubate them, take them off of that positive pressure ventilation, what's going to happen to their heart function? What's going to happen to their preload? It's going to go up. What's going to happen to their afterload? It's going to go up. What's going to happen to their cardiac output? It's going to go down. Not only that, but their demand is going to go up, right? Because now they have to do all the work of breathing. So now you have increased demand and decreased cardiac function. So what happens to that patient? They crump. Okay, they go into sometimes flash pulmonary edema. And we see this, we see these patients sometimes that look great on low levels of positive pressure ventilation, just CPAP and low level pressure support. We're doing a spontaneous breathing trial, which we'll talk about later. They look great. Their rates 15 to 20, their tidal volumes are good, their oxygen saturations, they're happy, they're going to get their tube out. You're happy, you're going to get the tube out. You extubate them, and an hour later, they're in severe respiratory distress. And that's frequently what the problem is. You've taken away that additional support. They had really marginal cardiac function to begin with, and now they can't handle it. Okay? All right. All right. What else do you want to think about?
That we follow commands.
Okay, so you mentioned earlier awake. You say following commands. So awake, alert, maybe following commands. Okay, how important are these? Do you have to be able to do all of these in order to extubate somebody? Can people breathe when they're not awake? Okay, so of course they can, right? You breathe when you're sleeping, and you don't have to be on a ventilator just because you're not awake. So, but there are a lot of important things that come along with being awake. Arousable awake, not just sleeping, and being able to follow commands. One is to be able to participate with your care, to cough, deep breathe, do all the things that we need people to do to clear their secretions and keep their lungs and their airways open. That's one important reason for the patient to be awake and able to follow commands. On the other hand, there are patients that will never wake up. I mean, we have patients that are in there are patients that are in chronic vegetative states that will never wake up in the sense that although vegetative state implies their eyes are open, but they're not really aware of their surroundings. Those people may never wake up, yet they're not all on ventilators. Some of those people live for years without ventilation. And they may need an airway, like a tracheostomy, so you can suction them, but they don't necessarily need to be on a ventilator for years. Okay? So you don't have to be, it's not an absolute requirement that you're awake and alert before you've extubated somebody. Your chances of successfully extubating them are much higher if they're awake and alert. Particularly if they don't have a tracheostomy or some easy way to access their airway for suctioning and secretions. But not, so my rule of thumb is if I think a patient has an underlying process where they have a reversible coma encephalopathy where I think they should wake up in a reasonable amount of time and be able to follow commands and participate, then I will wait for that to happen. If I think that that's going to be months down the line, like somebody with a traumatic brain injury or some kind of severe anoxic brain injury or something, and the family wants to keep going, then those patients you might trach, and then you might try and wean or extubate them. And then once they're trached, you just would wean and extubate them. So they don't have to be awake and alert in order to get them off the ventilator. It's just much preferable. Okay. And when we talk about successful extubation, what does that mean? Because I mentioned it.
Extubate them and don't have to reintubate them?
Yeah, extubate them, don't have to reintubate them for how long?
I think it's 24 hours is the...
There's not, I don't think, a great exact definition. Usually it's considered 48 hours. So if they're liberated from the ventilator for at least 48 hours, not reintubated in that amount of time, it's considered successful. You know, how successful is it when they're reintubated 3 days later? I don't know. But then you have to draw the line somewhere, right? Okay. All right, other things. So that's 3.
Can't be having too much secretions.
Okay, so secretions. So, can't have too much secretions. So what's the problem with secretions?
Mucus plugging and...
Okay, so you have mucus plugging. Anything else?
Aspiration.
Well, in the sense that you're not clearing your secretions, not necessarily aspirating. I mean, that's one of the reasons why you might want them awake and alert, so they can protect their airway. Because a lot of times we intubate, I should probably go back to that, we intubate people because they're a drug overdose. They're breathing okay, their oxygenation's okay, but we're worried that they're not protecting their airway, they're going to vomit or not be able to protect their airway. Secretions are going to go down in their airway and they're going to aspirate. So a lot of times people are intubated for that purpose. And when they're awake, that is no longer there. You fix that, you just extubate them. But secretions are mostly, I think, have to do with the fact usually these people have some kind of underlying inflammatory or infectious process. A lot of secretions, they're not clearing. If they can't clear their secretions, they build up. They can develop mucus plugging, which leads to atelectasis, leads to increased airways resistance, which increases the work of breathing even further. And leads to worsening respiratory failure again. In fact, secretions are probably one of the most underappreciated causes of failure of, unsuccessful extubation. People that seem to be doing fine, they get extubated, and then they need to be reintubated in less than 48 hours. That's probably one of the biggest reasons for that is they're not managing or handling their secretions adequately. So how do you assess that? How do you tell before you extubate somebody, does this person, are secretions going to be a problem for this patient?
Find out how frequently they've been requiring suctioning and how much has been coming out.
Okay, good. So you go to the nurse and the respiratory therapist and you say, how often are you needing to suction this patient? And how much are you getting each time when you do suction them? And what's the character of the secretions? You get a lot of information from just the nurse and the respiratory therapist. I mean, you can do it yourself also, but you don't know what's been going on for the last 8 or 12 or 24 hours. So you go to them and you ask them, and they tell you a number. Okay, well, they need to be suctioned every, what do you consider frequent? What do you consider okay? What's acceptable?
Anything every hour or less is too much, I think.
Okay, so if it's every hour or more frequent, then that's not good. That means they have really copious secretions. Every 2 hours, probably moderate to large amount, and if it's like every 4 hours, or they say, I've only, you're at the end of the shift and they've only had to suction them once or twice, that's probably a small amount, and I'm only getting a little bit at a time. What about the character of the secretions? Does that make a difference?
So the thicker it is, the more likely it's going to form plugs. The thinner it is, less likely it
good.
will.
So if they're thick and viscous, it's going to be harder for the patient to expectorate on their own once they're extubated, right? So that's going to be much more difficult for that patient. Whereas if they're loose and thin, usually you can bring that stuff up more easily. So the character of it is important too, not just the frequency. So is there any other way to assess that? Well, what else is important? The other thing is, well, okay, so say they have a moderate amount of secretions and, you know, they're fairly viscous or thick, you know, does that mean they're not going to be able to be extubated? I mean, you guys get colds, and I don't know if you've ever had pneumonia, but you cough the stuff up. I don't know if any of you have ever been intubated, hopefully not. But, you know, not everybody that gets secretions needs to be on a ventilator, clearly. So if they're awake and alert, what else can you ask?
The gag
Yeah.
reflex.
Well, not gag so much as what's their cough like?
Yeah.
Okay, are they coughing spontaneously? Some of these people are encephalopathic even though they're awake, and they don't really have much of a cough reflex. Okay, so they're not really even though they have a lot of secretions, they don't really cough until they suction them. Well, they're not going to get suctioned out like that after you extubate them. At least not, you can't keep that up for very long. You can do nasotracheal suctioning, but that's pretty noxious and traumatic for the patient to do for more than a day or so. So you want to find out, do they have a spontaneous cough? And how good a cough do they have? Are they able to really generate a good cough? And how can you assess that?
You do.
The pressures, maybe, when they're coughing.
Well, we'll come back to something with the ventilator and the pressures.
Yeah, I'm gonna
Is there
say-
any other way to
It's
do
like
it?
you put like a piece of paper off.
You've heard this talk before, haven't you?
Put a piece of paper in the tray and you have a cough and see if you get the sputum on
Okay,
it.
yes. So there was a study done a number of years ago called the white card test, okay, where they basically took a white index card, they disconnect the patient from the ventilator, and they put the card about, you know, I don't remember exactly, maybe an inch past the end of the endotracheal tube, and they had them cough as hard as they could. And if they could cough secretions onto the card, then it was a positive test. That implied they had a good, adequate cough because they could bring this stuff up. If they couldn't do that, it was a negative test. Went on, and then they went on and extubated all these patients and looked back at their, you know, how they did on that white card test. And the white card test was highly predictive of successful extubation. And the patients that were not able to cough stuff onto those secretions, they couldn't generate enough of a cough to do that, they had a very significantly increased failure rate and needed to be reintubated. So it's a simple, quick bedside test that you can do when you're just not sure. You know, even after you talk to the nurse and go through all this stuff, sometimes you're just not sure. And it's an easy thing to try. If they don't have any secretions, then obviously the test's always going to be negative because it can't keep nothing to cough up. So if they don't have any secretions, there's no point in doing it, right? Because they don't need to, you don't need to worry about it. So what if they do have a lot of secretions and their cough isn't all that great? What can you do? Well, you need to get back to treating the underlying problem. So if they have pneumonia, they probably just need more time. They may need more antibiotics. They may need bronchodilators to help them clear the secretions a little bit more. Do meta-naps. I mean, there are a lot of different things that you can do. You know, increasing their mobility and their activity, getting them up to a chair. All those things will help them clear those secretions. Sometimes they need anti-inflammatory drugs, steroids, depending on what the underlying problem is. Okay, so that's good. We're up to number 5. And you're saying everything because you've heard this talk before. What about these guys?
Yeah, I'll defer.
What about you?
Well, you can, in order to assess the underlying process, you can look at some of the measurements on the vent, like PEEP and peak inspiratory pressure and plateau pressures.
Okay, so that will, you know, PEEP, the settings, their measurements, the plateau pressure, peak inspiratory pressure, does give you some information about their underlying lung process, but it doesn't give you a lot of information usually about how weanable or whether they're extubatable. But there are other measurements that you can do, measurements on the ventilator, besides those that you mentioned, that can be maybe helpful, and we should talk about those. What are those called?
Like your RSBI?
Okay, so what is the RSBI? The RSBI stands for what?
The rapid shallow breathing index.
Rapid shallow breathing index, and that is considered one of a group of parameters which are often called weaning parameters. Okay, and those weaning parameters is really, again, a misnomer. They really, truly should be called extubation parameters because they're supposed to predict whether the patient is going to be able to be successfully extubated or not. So there's about a half a dozen of these measurements that we can make that are considered weaning or extubation parameters that are supposed to be predictive from one degree or another. And we'll talk about that in a second. So RSB, so I'm going to put weaning parameters because that's what they're always called, even though, like I said, they should be probably more appropriately called extubation parameters. Okay, so what are they? You mentioned one, the rapid shallow breathing index. Before we go into what that is, what are some of the other ones? Does anybody know?
NIF.
Okay, NIF, good. What does that stand for?
It's negative inspiratory force.
Negative inspiratory force, good. There's a lot of synonyms for this measurement, okay, which depending on where you're training or where you end up ultimately, they may have a different name for this. So do you know what some of the other things are? So another one might be maximal inspiratory force, another would be negative inspiratory pressure, and another would be maximal inspiratory pressure. They're all the same measurement, they're just different names. Here we call them NIFs, negative inspiratory force. But just so that you know, if you go somewhere else and they mention one of those other ones, you'll at least know what they're talking about. Okay, what else? Eric, it's up to you, man. You're blanking. All right, well, I'll tell you what the other ones are. So there's tidal volume, spontaneous tidal volume. There's vital capacity. There's minute ventilation. And I'm missing one. That might be it. I'll think of it if there's another one. All right, well, we'll start with these 5, 6, 5. Okay, so the first one you mentioned was rapid shallow breathing index. What is the rapid shallow breathing index, Eric?
So it looks at the frequency and the tidal volume, the respiratory rate and the tidal volume.
So it's the frequency over tidal volume ratio.
Yeah.
Okay. So the respiratory rate over the spontaneous tidal volume. And what should that be if it's to predict successful extubation?
So less than 105.
Okay, so less than 105. Okay. So this is called the rapid shallow breathing index. Sometimes it's called the Tobin index. Martin Tobin was the guy, the pulmonary specialist that developed the index or first described it. So some people call it Tobin index, though he doesn't call it the Tobin index. He calls it the rapid shallow breathing index. Okay, so less than 105. So how did he do that? In fact, how did they develop all of these things, these parameters?
Trial and error.
Trial and error.
Retrospective.
Well, most of them were really developed, yeah. They did all these on a bunch of patients, and then they went back and looked at, you know, what the different patients that were successful met, which ones they didn't meet, and they tried to come up with these predictive indexes or factors. So he did it prospectively. Well, I think he did it retrospectively and then tested it prospectively. And what he found was, or they found, his group found that of all of these different factors, as well as other ones that aren't on here, like compliance, they looked at a lot of different things. This was the most predictive of extubation success. Okay. Well, how predictive was it?
RSPR is pretty good.
Yeah, it's supposed to be the best of all of these things,
Yeah.
but how good is it?
So that was like 85%. Something
Yeah, it's
so.
probably around 80%. That means 20% of the time you're going to be wrong, right? Even with the best one of these, 20% of the time you're probably going to be wrong. The other thing is, how did they measure frequency tidal volume on these patients? Well, they measured it on a T-piece, which we talked about in the previous talk, right? That little T-shaped tube, which was the way we used to wean people from mechanical ventilation, take them off the ventilator and just basically let them breathe in and out through the endotracheal tube using this T-piece to give them oxygen. So that's how they did it. They didn't do it on tube compensation. They did not do it on CPAP and pressure support or CPAP and no pressure support. It wasn't done that way. So technically, if you're going to use this, you really need to do it on a T-piece. And virtually never do we measure this on a T-piece. Almost never. Okay? So when people say, oh, the rapid shallow breathing index is, you know, it's only 95 or it's 100, it's below 100, the threshold of 105, and you've done that measurement on tube compensation or on low-level pressure support just to overcome the resistance of the endotracheal tube with a little bit of CPAP, they aren't equivalent. That's not a fair test. In fact, there was one study, an abstract published several years ago, where they looked at that to say, if I have them on CPAP and 5 of pressure support, can I use that number 105? And that 105 moved down to 85. That became the cutoff if they were on that kind of support. So don't be misled by that 105. You really have to think about, you know, am I doing it the same way they did it? And usually we're not. And if you're doing it on tube comp or if you're doing it on low-level pressure support, and their number's 85 or 90 or 95, you need to think real hard about extubating that patient. Okay? At least if you're going to use that as your guideline of whether to extubate or not. I'm not saying you should, but if you're using that, you need to really think hard about it. Okay, well, what about these other things? NIF, negative inspiratory force. How do you measure that?
You have them take a big breath in, you measure, this is spirometry, you basically have a spirometer, they take a big breath in and just measure how much force they are to pull in.
A manometer, and they attach it to the end of the endotracheal tube. It's probably the best way to do it. And then they just tell the patient to take a big, deepest, hardest, fastest breath they can. And then they measure the maximum force or pressure, right? So what are you looking for? What's the cutoff for that?
I think it's, I can't remember the units, but 30?
Okay, so depending on where you read, you'll find different things. It should be more negative than minus 20 to usually minus 25. It's usually the cutoff, somewhere in there. So more negative, meaning they can generate a more negative force. So minus 30, minus 35, minus 40. What's normal? Any idea? What do you think you could generate?
When you take a normal breath.
Not a normal breath. That is a maximal inspiratory effort. That means going like that, as hard and fast as you can.
Probably 100.
Yeah, I mean, it's up around 90, 100, whatever. So this is pretty low level compared to normal, right? Just to give you an idea. Okay, what about the tidal volume?
It's greater than 500, I think.
Well, it's usually done in milliliters
Or
per
milliliter,
kilo.
yeah, so greater than like six, I think it is.
So you usually want it greater than 5 milliliters per kilo, and that's ideal body weight. Remember, everything in pulmonary medicine is, when it's weight-based, it's always ideal body weight. Why is that?
Because your lungs don't get bigger.
Yeah, because what is your lung volume dependent on?
Your height.
Chest.
Height, so stature, height, and what else? What are the main things that it's dependent on?
Diameter of your chest.
Sex.
Yeah.
Sex, good. So male, female. Females have lower volumes than males for the same height. And what else? Race. Those are the 3 major demographics that affect lung volumes and really all lung measurements. So it's always normalized by using ideal body weight, not actual body weight. In fact, when they went back and looked at a lot of the ARDSNet trials where you look at low tidal volume ventilation, in fact, not just in the ARDSNet trials, but when they've done surveys of how patients are being ventilated in ARDS across the country, even maybe across the world, they found that women and obese patients, in fact, there was just a paper published on this a few weeks ago, women and obese patients they're not getting low tidal volume ventilation because they're not adjusting properly for their lung volume for their stature. Okay, they're using the weights, the actual weight, not an ideal body weight, predicted body weight. Okay. All right. What about vital capacity? How do you do a vital capacity measurement? You guys don't get enough pulmonary instruction.
That's like all the way in and all the way out.
Okay, so you take the biggest breath you can in, and then you blow it out all the way. And that's a vital capacity measurement. If you blow really hard, then it's a forced vital capacity measurement. As hard and fast as you can. You measure from the top, the maximal inspiration, to blowing out as much as you can, as hard and fast as you can. That's vital capacity. So and you can do that while they're on the ventilator, so the therapist can do it. So what is that measurement? What do you want that measurement, the cutoff for that? It should be greater than 10 to 15 milliliters per kilo. Okay, and then the last one is minute ventilation. So what's minute ventilation? Spontaneous minute ventilation.
Respiratory rate times tidal volume.
Good, so it's frequency or respiratory rate times tidal volume. It's the minute ventilation. And that's the spontaneous tidal volume. Okay, and what do you want that to be?
Is that based on kilograms also?
No. It should be, but it's not. At least the number that they throw out there isn't. But you're right. Technically, it probably should be because your minute ventilation is probably not going to be the same as his minute ventilation.
Like greater than 5, I think it is, or?
Well, the cutoff is 10. Do you want it to be 10 liters per minute? Do you want it to be more or less than 10?
Probably less.
Less than 10. Why?
Because you want their demand to be lower. Because when they're acutely ill, they increase demand.
Okay, good. So you do want it to be less than 10. Can I erase all this? Some room here. We need a bigger. We already decided we need a bigger whiteboard. At least I do. Write too much. Write too big. I don't know. Okay, so you want the minute ventilation to be less than 10 liters per minute. So if you have a patient, you have two patients. You measure blood gases, and one of them, the PCO2 is 40. And the other one, the PCO2 is 55. And their minute ventilations are the same. Which one's doing better?
PCO2 of 40?
Yeah. So if this one needs to have a higher minute ventilation to get down to 40, then their lung function's not as good. Either their tidal volume's not as good or something about their lung function is not as good. So you really want a lower minute ventilation. Their demand, like you said, is going to be lower, and that's better. They don't have to breathe as much for the same, have to breathe as fast or as deep for the same level of PCO2. So what sort of things can affect minute ventilation?
PCO2.
PCO2. Well, PCO2 is maybe a driver internally for the chemoreceptors for minute ventilation, but what sort of things will impair minute ventilation or make it so that it's not where, what causes that problem for the same level of minute ventilation? So COPD may be one, so if they have obstructive airways disease. But what happens in COPD? What's one of the problems besides the airflow obstruction? What is actually happening?
You get the acidosis.
But why do they get that? Yeah, their CO2 rises,
Yeah.
but why is their CO2 going
Okay.
up? What really goes on? What's really happening to somebody with respiratory failure with COPD? Why do they go into respiratory failure?
You can inhale but not exhale.
Okay, so what happens when they inhale but not well, they are
Well, they
exhaling,
can't exhale,
but they're
but
not getting the air out of their
out.
lungs. So what happens when that goes on for a while?
Their CO2 rises and O2 drops. Because you could,
Some of it is the CO2, but what really why do they really go into respiratory failure? I mean, the CO2 is a marker of what's going on, but that's not really the physiologic process. What's causing the problem?
Respiratory fatigue.
Yeah, well, why do they get fatigued? What happens to them?
try to work too hard.
Okay, so their work of breathing goes way up because their airways resistance is up for whatever reason. They have bronchitis, bronchospasm, combination. What else is happening? Well, because they're not able to exhale completely. What happens? They get air trapped in their lungs. What's the effect of that? Aside from just the CO2 not exchanging, what else happens? So their lungs, what do they look like? What do their lungs look like on a chest X-ray when you take some?
Hyperinflated.
They're hyperinflated. So how can you tell that on an X-ray? What are you looking at?
Flattened diaphragm.
Flattened diaphragm. So what happens when the diaphragms are flat?
Don't work as well.
They don't work as well. Why? Because the length tension relationship with the diaphragm is totally messed up, right? Of the muscle. So you have significant impairment of muscle function in that setting, right? And that's why they go into respiratory failure. It gets progressively worse. It gets to the point where their muscles are just in a state where they barely can contract because mechanically they're at such a disadvantage. And that's probably one of the biggest reasons why people go into respiratory failure with COPD or with asthma. Because their oxygenations usually aren't that bad. You put them on a few liters of oxygen and get their oxygen levels fine. It's not the issue. It's not that they can't get oxygen into their blood. That's rarely the problem in those patients. Okay. All right, so what other things can make the minute ventilation increased?
I mean, a high respiratory rate, but what physiologically would cause it?
Well, yeah. Yeah, what are the other reasons why the minute ventilation may be increased? I mean, this person has increased dead space compared to this person, right? Because they're not expelling the CO2 for the same level of, theoretically, the same level of minute ventilation. They have increased dead space ventilation. So what is dead space ventilation?
It's where you're not exchanging gases.
What's dead space? If I have an alveolus and I have a capillary.
Large airways.
It's basically getting ventilated but not getting perfused but not ventilated.
It's the other way
The other
around.
way.
Doing
It's like a
ventilation.
PE.
So
Yeah.
you get ventilation, but you have no perfusion. Okay? That's dead space ventilation. Okay? So if I have somebody that has a high minute ventilation, that may be telling you that they have increased dead space ventilation. What are the ways that you increase dead space? One would be a PE. What else can increase dead space in the lung? There's actually a number of things that can increase dead space. So decreased flow. So if you have decreased cardiac output, really severe impairment in cardiac output, you're going to have increased dead space. Yeah, it's not no flow, but it's greatly diminished perfusion. It's going to increase your relative dead space. What else will increase your dead space?
Right to left shunt.
Pulmonary hypertension. Depending on the etiology of the pulmonary hypertension, yes. Okay, so if you have vasoconstriction, decreased flow, yeah, or intimal hyperplasia or something in the vascular tree, yeah. So yeah, that might increase it. What else?
Right to left cardiac shunt.
That's shunt, not dead space. Right? It's a definition, one of the types of shunt. So, what about if relative, when we talk about it, we're talking about, in a sense, VQ mismatch, an extreme form of VQ mismatch. If I over-distend the alveolus, what's going to happen? So if we're giving too much volume into this alveolus, you're going to have a lot of ventilation. It's going to compress the vessel. You're going to have decreased flow. You're going to get increased dead space with that. So if you use a lot of PEEP, you use a lot of, or have high PEEP levels or prolonged PEEP, like in APRV, you're going to have increased dead space ventilation. Okay? So those things will increase dead space. Anything else increase the PCO2? So dead space leads to an increased PCO2. Is there anything else that might lead to an increased need for a minute ventilation?